Hey there, good evening. Welcome back to I Care for Your Brain with board certified neuropsychologist Dr. Karen Sullivan. That is me. We are old friends at this point, aren't we? We have been on an education and empowerment mission for almost 3 years now. This is based on my very deeply held belief that you deserve to have detailed, evidence-based instruction on how to understand your personal brain health challenge and to have a set of guidelines to get the highest quality of life that you can get, no matter what your brain health challenge is. When we consider brain health issues broadly, we have normal aging, normal brain health on one end of the spectrum, and we have dementia on the other end of the spectrum. That is one of my areas of clinical expertise and has been a very, very important topic to me for a long time. So tonight I want to talk to you about the experience some people have when they are told you have dementia. When we consider the spectrum of cognitive aging, as I said, we've got these two extreme poles of normal aging and dementia. In the middle, we have something called mild cognitive impairment. And you need to understand these three things to be able to follow along well with my lecture tonight. So dementia means a very significant decline in one or more cognitive areas, decline in your independence in everyday life, and oftentimes mood and behavior changes. When you have this thing called mild cognitive impairment, or MCI, what it means is you have some drop in one area like memory, but you're generally independent. You're able to drive, you can remember your medications on your own, you can manage your checkbook, you can pay your bills, prepare for your taxes. That is really the distinction between mild cognitive impairment and a diagnosis of dementia. Now, for about 30% of people who get a diagnosis of mild cognitive impairment, over the course of 2 to 6 years, they transition into a diagnosable state of dementia. So for some people, it is a transition. For other people, they stay right where they are with mild cognitive impairment. One of my favorite things to do here on I Care for Your Brain is share interesting or important research articles with you that I've come across. And the one I picked on tonight is a recent study on the risk of suicide following a dementia diagnosis. Now, this is a very big deal to me in my world because I feel a tremendous responsibility having to tell people on a very regular basis that, in fact, they do have dementia. It takes many years of training, many years of experience with knowing really how to approach this very delicate topic with the maximum sensitivity and support. And the thing is, that's going to be different for every patient. I certainly have patients who respond to me telling them this with an acute sense of grief, very, very upset. Other people want to just talk about treatment. What are the things we can do? Other people can't take it in. They seem overwhelmed. Other people have a neurological inability to reflect on their own changes, and there is a poor self-awareness about the ability to comprehend. Look at that. I just noticed my terrible bruise there. I had some blood taken on my hand last week. Oh, showing you my hand, I was taken aback by that. I have to tell you that I think we need way more training in how to tell people of all types of brain health challenges what's going on with them. I way too often see patients come in who've really been traumatized with the way a doctor or neurologist has described to them what their condition is, what their prognosis is. I have seen people get diagnosed with Alzheimer's disease on their way out the door of a doctor's office. I've heard about this. I've had folks get a piece of paper to bring to the front desk so they can make their next appointment. And on the sheet, it says reason for next appointment, Alzheimer's disease. And they have never had a conversation with the doctor face to face. And that really bothers me. So tonight we're going to talk about kind of the most extreme form of an inability to cope once people get a diagnosis. Suicidality is again on a continuum, and we can think about it from having thoughts or ideas, but you'd never follow through, all the way up to a completed suicidal act. Dementia, it turns out, is both a risk factor and a protective factor. So I want to share with you some of that research tonight. It's definitely a serious topic, but I think it's so important to break some of these ongoing stigmatized topics and reduce any taboo that goes along with talking about these things, because the truth is Many people who don't commit suicide think about it. They sometimes have a fantasy of how it would stop the pain, and I think that it's a valid human experience that we have to make more normal by talking about it. In most countries around the world, older men are at the greatest risk for self-harm, including suicide, and the older people get, the more risk they are. We have to develop interventions for reducing suicide amongst older adults and figuring out what are the reasons that cause people to do that. So we know that there are several risk factors for later in life suicide. The most significant one is the presence of a significant mental health challenge, and clinical depression is most strongly associated with suicide in older people. But recently, a diagnosis of early dementia has also been identified as a risk factor. Previously, this had not been very well researched, and when you asked folks who had just been diagnosed with, say, Alzheimer's, if they would consider ending their life, only 2% of people in one study agreed to that and said, yes, that's true. However, when you interviewed their spouse or their child away from the person, the number actually rose to 15%, with those people saying, you know what, many times they've been talking about how they would do it. They don't want to live in a nursing home. They don't want to live not knowing who we are. And about 26% of the caregivers said that their loved one mentioned death, and about 9% reported that their loved one made suicidal threats on a weekly basis. So this is kind of the research backdrop. Just recently, a journal article came out in the Journal of American Medicine Psychiatry that looked at a registry of 148,000 U.S. military veterans, mostly men, who had been diagnosed with that middle stage of mild cognitive impairment, which, remember, occasionally, but not always, is a precursor to dementia. And what they found was that the risk of a suicide attempt went up 73% in people recently diagnosed with MCI, and it went up 44% in people who were told that they had dementia. And this is compared to folks who were not given a dementia diagnosis. So this data suggests this is a very important clinical situation. We have to increase our sensitivity about how we tell people they have dementia and all brain health challenges. But it also tells us that there is a very strong sense of anticipatory grief that happens in dementia. What that means is when you have mild cognitive impairment, you don't have dementia, you don't really have significant cognitive impairment, you're still independent in everyday life, but fearing the progression of cognitive and functional changes, fearing the loss of your independence, worrying that you're going to become a burden to someone, these are very, very strong risk factors. The biggest one, it turned out, is that belief that by having dementia, you would become a burden on other people. This was the most endorsed risk factor for suicide in these people. People in the early stages of mental decline are also much more able than people with advanced dementia to carry out a plan of suicide. So in some ways, it's just a practicality of being able to problem solve. The most common way that these folks took their lives was through firearms, guns, and what you have to remember is this is a group of veterans. They are trained in weaponry. This might not be representative of most people. But I can tell you, I have been involved in a tremendous number of conversations about getting guns out of homes when someone has advanced dementia and perhaps they are not safe with them or in fact may hurt themselves or other people. And by the time the dementia gets advanced, we're much more likely to have intervened with guns. So the research says that that's part of it too. We have another subtype of dementia called frontotemporal dementia, and 40% of these folks have reported suicidal ideation as compared to 8% who are kind of, normally aging. Frontotemporal dementia is sometimes called FTD. It is a spectrum of dementias that affect the frontal lobes, and people can either have a decline in language or a decline in behavior. And the behavior subtype is the most frequently associated with suicidal activities. That kind of makes sense considering the trouble with impulsivity, the behavioral outbursts that these folks typically can have. So when we just look at someone who's been diagnosed with dementia, there's about 5 primary risk factors that I want to get on your radar. The first one is if you've ever had an inpatient psychiatric hospitalization before. That puts your number up there. If you've ever attempted suicide anytime in your life. depression, clinically diagnosed depression, especially when it's accompanied by thoughts and beliefs that you would be worthless if you had dementia and feeling that you would be a burden. The fourth one is when someone has an awareness of the disease, when there's an intact insight and to reflect on what they perceive the losses are going to be. And the younger someone is, the more at risk they are. So under the age of 65. So why is this? Of course, this is the question that sits with me in my heart. I think it's very complex. Many factors. One thing that we really have to be mindful of doing is not reducing people with all cognitive brain health challenges, including dementia, into a one-dimensional being with that diagnosis as their primary characteristic of being a human. Okay, people come through a tremendously complex, busy, dense life before they get to a brain health challenge, and we carry all of that with us into older age and potentially dementia. So we have histories of trauma that are cumulative. We've developed positive or negative coping skills. And we also have a set of core beliefs that we carry around with us. Now, this is when I get to put my hat on as more of a clinical psychologist. We have basic, deep beliefs about, will we be taken care of during times of sickness? Will I be respected as a person? What if I can't stand up for myself? I lose my language. How will people treat me? Will I be protected or not? These issues really spring up when we start to talk about becoming cognitively incapable. I really believe the way people are told that they have dementia has a huge impact on the way themselves and the families start to consider and conceptualize the experience of dementia. If you put someone into a proactive, empowered stance and help them express themselves, and they don't stay all alone with it and their beliefs can get all warped, it's very important to have professional communication with folks at the beginning stages of dementia, because we want to talk through all of these fears that they have. Of course, we have a normal loss of independence. That's not something anyone wants. But there really is also an overlay of stigma. I am convinced of this. This is what we fear will happen to us socially. Again, how will we be taken care of? Who will respect us? Will we still be us? And so with these deep questions comes the very profound issue of, would we rather lose our lives or would we rather lose ourselves? And that is something you could write a PhD dissertation of. A lot of the researchers talk about the double sword of ageism and dementiaism in kind of a distress sandwich for people who are diagnosed with dementia, that we all know, especially in America, that older folks are not highly revered in many different ways. Poverty goes through the roof when you get older. Poor access to healthcare, unfortunately, is a very real thing. Elder abuse is rampant in some communities. So when you have both older age and you're losing your mind, this really puts some people into a no-win situation. We also have the very real brain fitness industry that I despise, that really hypes people's anxiety about what it means to lose your memory. Of course, being diagnosed with dementia can be absolutely devastating for very real reasons, but I truly believe that there are other reasons that are more related to the way we think about things, the way we treat people that we have control over in our society. Now, in some countries in Europe and in some states in the US, so in Europe, the Netherlands, Belgium, Luxembourg, have legislation for doctors to assist in the suicide or even administer lethal drugs upon request under specific conditions. And so they really focus on folks with dementia in two different ways. The first question is, can a patient suffering from dementia consent to the procedure? Can they understand the implications of what it means to take a deadly cocktail to kill yourself? Can they understand that they can have flexibility in the way that they think, right? Do they really understand what it is they're getting involved with? Decision-making impairments, the choice of options with kind of reward in the future and maybe some problems long term are cognitive flexibilities that people have to have a degree of cognitive ability to engage in. And we see that that is at a deficit in the early moderate stages of Alzheimer's. The second question, these are very deep questions, you guys, and I don't have answers, but I think they're worthy of talking about, is what is the nature of suffering in depression? Okay, so what makes it that a person would decide to be better off dead? And so one of the points that they make in the legislation is this is hard to judge, because when you are signing up to end your life, oftentimes people aren't saying, I want to do it today. They're saying, I want to do it if and when I get to the point where I don't know my children, when I can't, ask for pain medication, okay? But what you're doing then is you are anticipating your future days by assuming you will know how it feels in those days. And what people who are much more passionate about holding on to life no matter what the cost is that they say you don't know in that moment if you will be content or if you will be suffering. You will be unaware that you're not making new memories. You won't have a good ability to know where you are. So can your present self make a decision for your future self? Very, very deep. We have a very long way to go to improve the basic standard of humane care for institutionalized people who are living with dementia. Even the most perfect facility often involves people ending much of their independence, privacy, have to live with people they don't know, have to eat food they didn't prepare. Oftentimes there's locks to be unable to go outside. It is very, very different than how you might live in your own house for the most part. At the far end of the spectrum can even be abuse, theft, bone-crushing boredom. There's so much that we need to do to improve those qualities of life. And it would be interesting to look at countries. I know England has been amazing at developing some progressive memory care programs. It would be really interesting to poll that population and see if their thoughts about suicide had changed. Death with dignity laws, as they're called, basically mean the person themselves should have the right to make these decisions, not government, not politicians, not religious leaders. And they typically go by if you have 6 months or less to live, and it's a voluntary request, okay? So how they do it is 2 physicians must confirm that you live in one of the countries or states where it's approved. In the United States, we've got California, Colorado, District of Columbia, Hawaii, Maine, New Jersey, New Mexico, Oregon, Vermont, and Washington. However, the Death with Dignity National Center has not endorsed any specific advance directive for Alzheimer's or dementia. So the laws exclude this part of our community, and it's just unclear where they fall on these people's ability to make decisions for themselves. So the gap that's opened up is to encourage something called an advance directive. Now, I know all about advance directives from my awesome mom. This is her area of focus in social work. And what this is basically you can instruct what you want to happen at the end of life. However, many times these are not considered legally binding in some countries, maybe not even ethically binding. So it gets a little bit complicated, but having one is certainly better than nothing. And so this data it's just thought-provoking. It really gets me thinking about quality in life with dementia. What do people assume happens to you once you have a dementia diagnosis? I have plenty of patients who are absolutely happy as a clam with dementia. 2 people right now that I'm caring for frequently are very much in the moment, absolutely love every second with their family member, are laughing all the time. It's just one rolling into one good moment to the next for them. And of course, that's a unique experience, but it's to really say not everyone with dementia is going to have a horrible end of life. It's really different for different people. So I do this Facebook program once a week to give you good scientific instruction so that way dementia becomes demystified for you. I really believe that part of the anxiety we have about dementia is not knowing. It's like a big ball of smoke. Many people don't really understand what it is and really don't understand the power people have to reduce the likelihood that they're going to get it. So if you have someone that you know who's recently been diagnosed with dementia, or maybe, I encourage you to be a good friend. You don't have to have the answers. You don't have to know what to say. Letting people talk and express themselves, reassuring them that you are here no matter what happens. You will always be there to support them no matter what happens, is sometimes the greatest medicine we can give people. If you believe somebody with cognitive impairment is considering self-harm, I want you to really monitor the symptoms of depression. It turns out when you add depression and dementia, that's really where people get into trouble. So signs of depression for many older folks are more social withdrawal, apathy, not caring, saying I feel sad, crying more, and saying things like, I wish I could die, I'm thinking about, hurting myself. We really want to take statements when people say, I don't want to feel like a burden, or I feel like a burden. That is really, really an important tipping point. Take guns out of homes, okay? You can call the police to remove them. You can say they got lost. You can say they're getting cleaned. We gave them to our grandson. They're broken. I have been a part of many white lies involving guns. It's just not worth it if there's a risk of self or other harm. If you're concerned about this issue, please bring it up with a compassionate doctor. There is a wonderful suicide helpline that I'm going to post in the comments that's free and confidential. And consider, the advanced directive idea. What do you want your end of life to look like if you were diagnosed with something like Alzheimer's disease? What is it that you would want for yourself? But I also encourage you not to make too many binding decisions until you've become really educated about the subtypes of dementia, what you can advocate for in terms of care, and what are the ways that you can reduce the likelihood that you will get dementia. There's a lot of modifiable risk factors. And this is really the inspiration behind this I Care for Your Brain School that we're starting on April 8th. It's really about dementia prevention and what does science tell us we can do to try to reduce dementia in our brain health community. So if you follow me here because you have some type of a challenge, stroke, movement disorder, early dementia, family history of dementia, high blood pressure, type 2 diabetes, sleep apnea, depression, it goes on, the things that affect the brain, this unfortunately raises your risk for dementia because you already have some element of a neurodegenerative process that's happening in your brain. And so I have designed this program to really make sure that this community, you in my brain health community, understands all of the power that you have to fight back against dementia. So if you haven't signed up yet, I want you to consider it today because we're filling up pretty fast, and I want to make sure you understand how it's going to work. So once a month for 9 months, we are going to be doing a 90-minute evidence-based lecture on Zoom, and with each sign up, you're going to get a 68-page color workbook directly into your email inbox. And in that workbook, you get all my slides, you get behavior tracking sheets to put my recommendations into place. It has been such a nice experience being with you here for 3 years, but I can tell you there's so much more that we could be doing and learning together when I'm able to do my talks the way I do them in my community in North Carolina or with my patients in my office. This is where I get to incorporate my slides. We're able to personalize the information. We're able to take questions, expand on things. When I come here to Facebook, it's like a 20 to 30 minute lecture. It's me, talking to you, hopefully educating and empowering you. In my webinars, it's a lot more back and forth. You get a lot more in-depth information, and you really get to understand how to put it into practice. So I'm very proud of the program, and it would really be wonderful to me to have it full and to see all of you there. I think it would really be a great showing that people care about this type of information. So if you go onto our website, icareforyourbrain.com or ICFYB /school, you can become my personal student. And we have done webinars before with stroke recovery, essential tremor, orthostatic tremor, Parkinson's disease, and it is always an absolute blast. It's literally the thing I look forward to most all month. I love sharing that time with you all. And I really, really hope that you will go sign up right now. We get started in 9 days on April 8th. And what we're going to be talking about then is the aging brain. It's really the primer to get you properly educated to take in everything I'm going to teach you over 9 months. All the information I know about the aging brain and dementia prevention, basically it's a program of taking my brain, putting it into my slides and into your lives. So I'm very excited about it. I will be back with you very soon, and thank you so much for listening. Very important topic tonight. I know I'm gonna keep giving it some thought. Please share your thoughts with me in the comments below, and let's keep the conversation going. Take care, you guys. Bye-bye.